Arun. Uh, the audiology setups in UK.
Hmm.
Uh, Tell us something about the audiology setups which focus on vertigo, audio vestibular or whatever. Or
It's
give us
it's
some idea of the UK system.
I think no system in the world currently is perfect when it comes to vestibular disorders, I think as a whole. Only because there is an increasing patient population, as everyone getting older, etc. This number is constantly increasing. Number two, most of the knowledge base around vestibular disorders has only come about in the last 10, 15 years. When in terms of the actual diagnostic criteria, in terms of the actual management options that we have now. So most of the current services are still predominantly based on very old setups whereby it will end up usually under the care of an ENT surgeon. And subsequently, what we'd like to do is to try and improve that the initial diagnostics and the initial feedback and have an escalatory pathway whereby if, let's say, something's a bit more complex, then to escalate things appropriately. Now, what happens in reality is that lots of patient ends up bouncing between various specialties, and that happens in the UK, that happens in the US, it happens everywhere, unfortunately. So instead, what's happened is there are now these niche, very super specialized clinics, and number two, there are um, other what was I going to say? There are very niche, super specialized clinics, number one, and number two, there's a bit of discrepancy and variability in the services that are currently available. Um, Going forward, my advice is, of course, and what we're trying to encourage, is like in India, is to encourage audiology diagnostics, so that audiologists, ENT surgeons who are interested, neurologists who are interested, all have the same level of at least basic ability to be diagnosing the basic conditions, at least, and to treat them early and effectively. And it depends on someone's interest. So it could be an audiologist with an interest, it could be an ENT surgeon with an interest, it could be a neurologist with an interest. But finding these people with an interest is the hardest part at this point, isn't it? Because it's still not considered a very exciting area of medicine. And so I think anyone with an interest should all come together, bandy together, and try and provide the best quality of care that we can. And then if we can't manage it, then to direct the patient appropriately to the correct direction.
And associations, do you have, like you have an otology association, is there a vestibular association?
So the main difference in the UK from that perspective is that there is the British Association of Audiovestibular Physicians, because as you were saying earlier, I think I walked in halfway through the conversation, it is very super specialized in the UK. So me now as an audiovestibular physician, I've gone long way away from ENT. So even the training pathway becomes separate. Initially I trained in ENT, and then halfway through switched the training pathway to become an audiovestibular physician, where it's a 5-year
Does
training program.
does that apply to the audiologists also, or do they become jacks
No,
of
I
all?
think, and this is where we do need to get a bit more structure. And actually, I would encourage any audiologists who are listening, any physicians who are listening, etc., that actually further training is absolutely imperative, because at the moment it's very much training on the job, training, and that leaves a bit of scope to a variation in care and variation in the training. You'd only be as good as your trainer. You'd only know what your trainer knows. And I think that's the one thing we're trying to move away from in the future of medical and allied professional education.
So I think we have quorum enough to start. So
Absolutely.
Arun,
Yeah,
I leave the mic to you. It's your show. I'm
uh,
just flitting in and out.
of
Go ahead.
course. Well, I'll let, is it Banish, if I'm saying correctly?
Yeah,
And
sir.
Vishnu to,
I am one of the co-presenters. We'll let
perfect. I'll
Vishnu is
let
going
you,
to be the one who's going to be sharing the presentation.
sure.
So he's going to be the one who's going to share the screen. Vishnu, could you do that for us, please? Could we go to the first screen of the presentation? So I'll just start off. The topic for today, which we have chosen, is cluster headache with coexisting vestibular dysfunction in a young adult. which is a very rare finding as seen by our clinician Vishnu. And yeah, we'll move to the next slide, Vishnu. So I'll just give a little uh, info on the abstract. Cluster headache remains one of the rarer forms of headaches with a broader spectrum of debilitating impacts. It is marked with sharp unilateral pain and is associated with autonomic features such as lacrimation and nasal congestion. Vestibular symptoms and dizziness are a commonplace in migraines, but the documentation in cluster headaches is rare. We report a 22-year-old male with classic symptoms of cluster headache and vestibular complaints. A thorough vestibular assessment with video nystagmography demonstrated both peripheral and central vestibular dysfunctions. The case demonstrates the need for a foundational vestibular assessment in cluster headaches, as well as neurological assessment when faced with non-traditional headache presentations. From the case, there seems to be arguments in favor of interdisciplinary assessment and management of patients with headache and argue for the support for targeted intervention. Next one. So cluster headache is considered one of the trigeminal autonomic cephalagias. According to the IHS ICD-3 framework, it is marked by intense one-sided orbital or temporal pain. The pain is often accompanied by autonomic symptoms such as lacrimation, conjunctivital injection, rhinorrhea, and ptosis, generally occurring in young adult males. Or cluster headaches greatly lowers quality of life, particularly during active cluster phases. Dizziness and vertigo are commonly encountered in conditions such as vestibular migraine, BPPV, and Meniere's disease. But these symptoms are infrequently recognized in the context of cluster headaches. Most literature on cluster headaches disregard vestibular symptoms as an ancillary to the diagnosis. However, some emerging literature suggests that there could be some pathophysiological convergence between mechanisms of pain and of the vestibular system, specifically in the brainstem and posterior hypothalamic areas. So the functional neuroimaging studies employing PET scans and MRIs have shown activation of posterior hypothalamus during CH attacks, a region associated with central vestibular regulation. Yeah. Roca-Filio et al. In 2018 documented vestibulo-ocular dysfunction in trigeminal autonomic cephalagias. Patients with CH and other TACs were evaluated for balance control, gaze control, and oculomotor tracking. Identified some clinical abnormalities, reserves even in the absence of dizziness, suggesting some central vestibular system involvement. The conclusion over here is that TAC patients with objective vestibular signs lacking overt vertigo indicate subtle dysfunction sculpted in brainstem vestibular pathways. Kine and Hood in 1984, vertigo as an atypical feature in cluster headaches. An observational case series of such patients described the presence of vertigo and dizziness either coexisting with attacks or in the interval between them. The authors evaluated the relationship in the time between episodes of vertigo and cluster intervals, proposing some common involvement of the vestibular nuclei and trigeminal system in the brain, considering the symptoms and their overlapping structures. So the conclusion over here is the first clinical hypothesis of the brainstem convergence causing vestibular systems in cluster headache, which was done in 1984. Vishnu, next one. Yeah. And similar studies done by Bonoliel et al. In 2017 suggest that trigeminal autonomic circuits for multisensory involvement, review of trigeminal autonomic reflex pathways, and central sensitization from neuroanatomical and functional studies. Incorporated results from preclinical models and human neuroimaging suggest that and demonstrate how autonomic and pain centers can be activated, impacting broader sensory areas. Cross-sensitization of neighboring systems particularly balance and spatial orientation networks, may result from the repeated and prolonged activation of these circuits. In conclusion, central reflex pathways are triggered in cluster headaches that are triggered in cluster headaches may affect vestibular and proprioceptive systems in addition to pain regulation. So now Vishnu is going to take over and talk about the case. I just gave a little introduction on what cluster headaches and typical vestibular associations go with it. So Vishnu, I would like you to take over what your findings were and what you saw in the case.
Yes, sir. Good evening, sir. Yes. The patient presented were a college student, 5 year of history of episodic sharp and stabbing right-sided headache. The located area was the temporal and the frontal areas. Each episode lasted approximately 45 to an hour, and or it was co-occurring during the vertigo co-occurring during the headaches episode also.
Okay.
The headache were consistently accompanied by the right-sided nasal congestion and watery discharge from eyes and nose both. Notable, the patient described the recurring sensation of imbalance floating during the most headache episode. He denied symptoms commonly associated with vestibular migraines such as the photosensitivity, visual aura, or even though no audiological symptoms were there, the tinnitus, the oral fullness, like fluctuating hearing loss. So uh, this patient was medical and this patient's medical's family history was non-contributory and maintained a healthy lifestyle without tobacco, alcohol, or substance. It was substance-free totally. And also patient with initially experienced the nauseatic, but vomiting, no, there were no vomiting at all. Clinical vestibular examination was neurological examination such as the skew deviation, head impulse test, gaze and all were uh, in the head impulse test. They were showing the corrective saccades, bilateral corrective saccades, and skew deviation was a mild deviation, but we can see it was in a normal line within normal limits. But there was the Fukuda test. It was forward and right-sided more than 45 degree and forward more than 1 meter. The Romberg were normal at Dixol pike and supine head roll, and also the head hanging test was showing the pure horizontal nystagmus, mostly agiotropic nystagmus. The VNG stemography protocols were a VNG test was administered. The saccadic evaluation revealed that horizontal catch-up saccades on a horizontal and vertical was showing hypermetric. Smooth pursuit test showed a markedly reduced horizontal gain with frequent saccadic intrusion in a left eye mostly. Optokinetic test left to right revealed minimum upbeating and saccadic oscillation in the left eye with no optokinetic response, while right to left also showed absent optokinetic responses, absent gain at all. Bottom to top revealed increased gain in the left eye, or top to bottom revealed gain within normal limit, and no sign of horizontal nystagmus in a vertical tracing, top to bottom or bottom to top. These are the recordings. Saccade is horizontal.
I feel there is a little lag in the video. Otherwise, there's a pure horizontal beating nystagmus as it can be seen in the graphs also, even during the saccades over here for the patient, right, Vishnu?
And yes, when in staying on the target, it's showing the corrective saccades on the left and right, bidirectional. You can see there
Okay.
in a
Can
horizontal.
you play that again, actually, please, if that's okay?
Uh,
Just one
yeah,
more
sure,
time.
sir.
Can you play the vertical one also, Vishnu, alongside this?
There is a hypometric saccades bidirectional. Uh, we can say the corrective saccades, but there is mostly showing hypermetric, underestimating the time, overestimating the time of the target actually, or distance. Smooth pursuit,
Yeah.
horizontal showings, intrusions bidirectional. When it goes to right, it's showing the catch-up saccades. When it goes to left, it's showing the catch-up back saccade actually. See, when we
How,
see in the waves.
and was the patient having vestibular symptoms during these video recordings, or were they asymptomatic, or when was the last attack they had?
Last attack was 2 days ago. While recording, there were no vertiginous. He didn't feel anything.
Fine. So 2 days ago was the last attack of
Yes, sir.
vestibular symptoms.
Per week, it's a 3 or 4 episode he experienced, maybe more, but it's a minimum
Mhm.
3, 4.
And what were the vestibular symptoms again?
Vestibular symptom, dizziness,
Mm-hmm.
possibly while occurring with a headache also.
Co-occurring with a headache,
No,
usually,
yeah,
sometimes. Okay, not always.
sometimes. Not
And then
always.
into how
Mostly
long would
co-occurring with a headache only.
okay, and so it would last for that duration, the 1 hour, basically.
Yeah, 45 to 1 hour or 1.5 hour. That's all.
Perfect. Okay.
The vertical smooth pursuit. It's showing the the reduced downwards gain. Here and here. Intrusions, but mild.
But still, I feel it's still there is a constant horizontal deviation
Horizontal is
which is
yes,
happening
sir.
during even the vertical movements, which is there. That's what I was trying to mention, that in the presentation which we have prepared, the video is very smooth in terms of frame rates, which is showing a very good horizontal movement. But when we are presenting it here, and due to the internet lag, there seems to be a little lag. It's a little jerky. But definitely, sir, we'll get your mail and we'll share this to you. We would need insights from you and even Dr. Ravi on this. It felt to me one of the very uniquely observed eye movements. I have also personally seen, at least I would say, administered over 600 to 700 VNGs, something in between. But this is one of the very rare eye movements which we have recorded, especially for such a young case.
And this is an nystagmus at the end. And I appreciate the video, as you mentioned, is a bit patchy. But is this actually sort of horizontal nystagmus, or is it
Yes.
a saccadic flutter at the end?
So it's a nystagmus.
Yes, sir. A saccadic oscillation is also there, sir, but in optokinetic, in positional traits also. Yes, there it.
Yeah, because when I'm looking at it from this end, it looks potentially like a saccadic flutter at the end where you get to it. But of course, the video, lag always makes it a bit difficult to pass full judgment on it.
Yes, that's what, sir. Because yes, I also was shared. I was traveling. Vishnu shared me the video
Sure.
and I saw it, and I can definitely say that it is nystagmus, which is the continuous nystagmus. It's not jerky. It's not like there's a continuous, spontaneous nystagmus, even if the patient is not following or tracking or, if for
Oh,
some
of course.
smooth
Yep.
pursuit. It is
No
just
doubt.
I have some
observed.
videos also, so I
Just
No
can
doubt.
mail it
just
to
can you
you.
just like after the presentation, we'll just see if
Sure.
playing
That's
the
fine.
video seems to be a bit better, because this is a part of a presentation. Maybe that's
Fair
why
enough.
it'll be lagging a little bit.
If not, you can send it to
Uh,
Vishnu and we can have a look afterwards. But yes,
Yeah.
we'll talk about. So there's an underlying resting horizontal nystagmus beating to right or left.
Bilateral,
What do you
Bilateral,
mean?
mostly bilateral.
primarily, I would say they twist.
Biphagic nystagmus showing mostly biphagic nystagmus. There is a multidirectional, some on some test it's showing the downbeating, some test in upbeating, some is
Okay,
showing
so
right, some left.
just to clarify, going back to midline position, if they're looking straight ahead without visual input, was there any nystagmus and which direction was it
Yes, sir.
beating if they're looking straight ahead?
It was bidirectional, sir. It was like
If it's
back and forth,
bidirectional,
back
then
and
we'll
forth.
call,
Yes, sir.
then I wouldn't label it potentially as nystagmus, because if they're looking
Yes.
straight ahead, nystagmus would be beating to one side, or it would be direction changing and beating to the other side.
Yes.
Or if it's fluttering like that, then we'll call it more flutter or opsoclonus or one of the other names that we use for it. So that's why I was trying to clarify, because of course in the video we're seeing here is at the end, there's a bit of oscillation at the end. When it goes to the end, there's a bit of oscillation. And so when you're looking straight ahead, were they firstly beating to one direction and then changing direction and beating to the other direction? Or was it doing that?
It was like changing the direction. First, it was going the right, and then go left. Then it's same in the mid. It's going the flutter like. Then it's going the right, and then it's going left. It was like
So
that.
Can you just play the video over here, Vishnu? All two,
Uh,
three of them? Like let's
Oh.
just first one.
It's an optokinetic, left to right.
oh, this is optic. Perfect. Thank you.
Just play the second one also along, Vishnu. This is right to left. From right to left, you're seeing very minimal movement, which is there compared to.
Less intense compared to the left to right.
Yes. Just play the last one also, Vishnu, which is bottom to top.
Bottom top to bottom were normal. Gain within normal limit.
See. So bottom to top also we are observing a horizontal movement over here for the patient.
Seeing in bottom to top showing the horizontal nystagmus also here in
Yes.
graph.
Yes, definitely. This is much more evident than the first two ones.
And in horizontal, there is no optokinetic response in both right to left or left to right. There's no optokinetic response at all.
It's not
No
reflected.
gain.
Yes, no gain. Okay.
So spontaneous in light reveal horizontal macrosaccades in a left eye, and spontaneous in dark reveal mild upbeating and momentary downbeating nystagmus. And hyperventilation shows left up and downbeating nystagmus, and head check or high frequency head check shows left down and momentary upbeating nystagmus. Gaze test with or without fixation reveal pre-existing nystagmus, are same beating nystagmus, but momentary mostly. With reduced intensity. Head positional revealed up, down, and left beating nystagmus in your right and roll right and your left and roll left. Pitch backward and Forward shows mild upbeating nystagmus. These are the spontaneous light.
Primarily seems to be like a left beating over here.
So I think it's obviously, from my end where I'm looking at, I would find that difficult to ascertain a direction of nystagmus on that one. It's going either way. So that, on primary gaze, we either would, if it's going both directions and there's a difficulty, we can call that square wave jerks, because there's a term for it known as square wave jerks, assuming it's the same as what we're seeing on my screen here compared to what you have. Or you can call it particularly the end gaze. So let's have a look at the spontaneous and dark, if that's okay as well.
Yes.
So it's a bit more obvious, it's a lot more obvious, isn't it? But again, I'm seeing it bobbling in all directions, in any direction as well. So again, the term nystagmus would less likely to apply in here, because there's not one clear fast phase and one clear slow phase. It's going all over the place. So, do we label it as square waves, or do we label it as like a ocular flutter of some sort?
Sure.
So it's yeah, but either way, it's a very central looking set of eye movements, isn't it? The whole picture, include, showing brainstem, as you rightly mentioned, brainstem and cerebellar involvement potentially. So that is very
So we
nice.
can't call it ocular flutter, because ocular flutter, which is like the intense jerky movement, this is kind of the microsaccades. It stays, it goes right and then stays, then it goes left. So
Yeah.
ocular flutter is just like jerky movement. You will go
It'll
like
be
that only.
it'll be the very obvious ones, yes, and then you get milder versions as well. But equally, as I said, the other term you can potentially apply here is square wave jerks.
Yeah.
But it's going a bit more all over the place as well. So yep, it's lovely, lovely eye movements.
So I documented as a microsaccadic oscillation. This is the spontaneous light in a left eye. So this is a hyperventilation. There is showing left beating and down beating, but left beating is more intense. So this proves the neurovascular system that activate the hypothalamus. This is the high frequency head share.
Yeah, the videos are certainly a bit laggy, aren't they? But we can now see it, that left beating a bit clearer on here, and certainly it's being picked up on your traces as well, with the fast phase and the slow phase down.
Yes.
Although,
Charles?
sorry, if you go back 1 second very quickly, I was just looking at that bottom trace there. Just wondering
The
if that was a bit of reversal randomly in the right at that right-hand side
Vishnu,
at the trace,
Vishnu,
looking at the
Vishnu,
trace.
do you have, we have the PDF in the laptop, right? Can you just go out of this presentation and show the proper, the tracks?
Don't worry. Let's finish the conclusion first because
Okay.
it's interesting, and we'll come back.
Okay.
And I'm just looking at that trace at the bottom, which is interesting.
results were the VNG results showed that the vestibular system was involved in a two ways bilateral VR hypofunction and positive head impulse tests showed that peripheral involvement was present. Some of the central ocular motor problem were hypermetric vertical saccades, downbeating nystagmus, and saccadic intrusion during pursuit tests. Meaner disease and vestibular migraine were ruled out because there were no auditory symptoms or migraine-like features such as the aura, photosensitivity, or migraine headache longer last than this presentation. There was no fatigue of delay in the nystagmus that would point out to BBB, and the duration also less, very less, 15 seconds. These results didn't match either isolated peripheral vestibulopathy or the dizziness that usually comes with migraine. The combination of peripheral VR loss and central nystagmus pattern, on the other hand, supported a diagnosis of cluster headache with vestibular dysfunction at the same time, which is an unusual but clinically important presentation. The discussion. It is not a common for a person with the classical cluster headache to also have vestibular dysfunction. Dizziness is not a main sign of cluster headache according to ICSD-3. This case adds the growing body of research that recognize a wider range of neurological symptoms. Neuroimaging studies have shown that the posterior hypothalamus involved in the pathology and pathophysiological of the cluster headache. This area is connected to the vestibular nuclei and the descending brainstem pathway in a way that makes sense of the vestibular symptoms this patient is having. Uh, these results are in line with the earlier research by uh, Roca, Filho, and others that say trigeminal autonomic cephalogias can affect balance and eye movement control through these shared pathways. The diagnostic process carefully ruled out vestibular migraine, Meniere's disease, and BPB, as each of these conditions usually has its own set of clinical sign that were not present in the case. In this case, the fact that both sides of peripheral VR hypofunction are not working properly, uh, and the central oculomotor system is not working properly, support the idea of hybrid dysfunction that may only affect a small group of cluster headache patients. Requirement of vestibular evaluation is patients with primary headache disorder who experience dizziness or disequilibrium is further strengthened by this case. Overlook these symptoms, it results in a misdiagnosis or insufficient treatment, especially when the presentation is not typical. The conclusion, this study highlights an infrequent but clinical significant connect between young adults who have vestibular dysfunction and cluster headache. It emphasizes the importance of multidisciplinary evaluation and support the use of meticulously vestibular testing in patients exhibiting unorthodox headache symptoms. Understanding this overlap could lead to better patient outcome by enhancing diagnosis and treatment plans. Reference as Headache Classification Committee of the International Headache Society, IHS. The and in IHS we took the reference from the ICSD-3, Lamberti Neurensure and Epidemiology of Vertigo. We also took reference from that. May and it is the article that we took here.
So, just to get
Yes,
some
sir.
clarity from my end, could you just tell me something about the headache? Could you describe the headache? Because the point is that vestibular system aside, the point is you're linking it to a cluster headache. Now, cluster headache is a very, very specific kind of headache. So, I would have loved to hear some description of the headache. If that is possible, I'd like to hear it.
So the patient were experiencing the headache, sharp, stabbing headache, unilateral, mostly right-sided. It was episodic and occurring. If we talk about in a week, it occurs minimum 4 to 5 times, or maybe in a day 2 3 times. Sometimes most of the day, maybe in a week 3 times. So it
And
was
any
mostly intermittent.
and any triggers?
No triggers, sir. Nothing. No positional triggers.
And this has been going on
No
for how many years?
5 years.
5 years. And does it occur in clusters as the
Yes,
name
sir.
suggests? It did occur. Okay,
Yes,
very
sir. It's yes, sir. It also lacrimation, the
good.
autonomic structure suggesting the rhinorrhea, the nasal congestion,
And
and the
any laterality, or was it how was it, temporal, or was it,
yes, sir. It was on a frontal and temporal area.
so it seems like
Primarily
Mostly
towards right
described as a
side.
yes, sir.
Towards right side, yeah. Yeah.
so I think we can throw this discussion now. Arun, how would you like to take this on? So I would ask you, how many cases like this do you see? Do you all manage headaches, or do headaches come to you?
I
Sir, I
think,
want to sorry,
Sorry?
yeah, sorry,
sorry
go
to
on.
disturb you, sir. I want to sir, point out something. Uh, Sir, these neuroimaging PET and fMRI, sir, it shows the activation of hypothalamus while the clustering headache. Or I took these pictures from May in Bahar.
Yeah.
So, firstly, listen, I'd like to say well done for putting together a presentation just the way I like it, which is with evidence and reviewing the evidence base and with the appropriate references. So that's excellent. And of course, you've done your research onto what a cluster headache is, and by your description, is certainly. I think probably Dr. Nair would agree as well. It does sound like a cluster headache more than a migraine, doesn't it? And even though cluster headaches are exceedingly rare, it's being important to sort of pick them up. There's interesting also this very clear overlap between migraine and cluster headaches in terms of its pathophysiology, in terms of trigeminal nerve activation, in terms of all of those other various factors, which means that I suspect there'll also be some overlap and the possibility of vestibular symptoms, which makes sense. Now, to answer Dr. Nair's question, we basically deal with anything to do with central vestibular dysfunction, be it headaches, be it dizziness, be it any other sort of associated autonomic symptoms, at least from our perspective in the UK here. Going back to your presentation itself, I think, listen, you're right, as I was rightly saying, as I was saying earlier about the headaches, that it seems unusual. You're right that they have certainly very much vestibular symptoms, and there are lots of central, without having to sort of go into the nitty gritty of having to label them individually, there are huge amounts of central vestibular signs which point towards brainstem and cerebellar dysfunction. Now,
Yes, sir.
two things is, have they been investigated otherwise? Because, for example, any migraine disorder, any central cerebellar or vestibular dysfunction, any atypical headache, I would think of making sure that they have blood test, MRI imaging. Would they think about alternative causes for their symptoms, including toxicology screen, etc.? It is a young person after all. Have they had all these previous investigations before, and were there any positive findings from them?
Yes, sir. Sir, he did MRI, but it was
Good,
normal.
good, okay.
Was
And
normal. Then he was like bearing the pain and going through the 4 years. Then he thought I should do something about it. Then he come to me for testing
mhm,
with no doctor reference, nothing. He heard somewhere that you
mhm,
find the central or the peripheral cause. What is that too? So I did the test and then I referred to him, the neurologist.
Perfect. Okay, and maybe a very specialist neurologist, and this is where we need to, as a clinician yourself, you're the best advocate for the patient, to know where to send them to someone who may understand this condition a lot more and what it causes. So absolutely, that's the right thing to do. And as part of it, you'd want to do the blood tests, including looking for other causes of neurodegenerative causes, neuroinflammatory causes of similar symptoms. And once you rule that out, then we can definitely go down the cluster headache plus vestibular symptoms route. The main question I had is, how certain are you there is a peripheral vestibular deficit? Because all of those eye movements we saw, very much we can be fully categorized into central as well. And you can even get, horizontal one-sided beating nystagmus from a central pathophysiology. You can get positional nystagmus. You can get all sorts of central eye movement signs. So what evidence do we have that there is significant peripheral vestibular deficit in this particular case?
Sir, head impulse test showing the bilateral corrective saccades that
Is it
leads
video?
to.
Is it video head impulse test?
No, sir, that
Or
is not available
clinical?
in this laptop.
Okay, clinical head impulse. I would think about, and this is where, again, if you're building a service and you're thinking about, doing all the other vestibular tests, certainly it will be an appropriate thing to put them through the vestibular test battery
Yes.
Yes,
aside
sir.
the
I was
VNG,
trying.
because, yeah,
Sir, I was trying to reach out to him, but he's not from Delhi actually. He
okay,
went
yeah,
out, so whenever he will be here, he will come to me and I will assess the more test and present this case in with lots
yeah.
of proof.
I think what you
This is
need
because this is
definitely would be
one.
worthwhile doing the whole
I,
works on him,
I would like to.
particularly.
Can I add
Yeah.
something, sir, over
Hmm.
here? So, sir, as Vishnu mentioned, the patient came through a reference. He got to know from someone that
Yeah,
he's to be,
which is good.
diagnosing the peripheral or the central thing.
Yeah.
One challenge which we are facing, and it's not just in our practice, because I travel around due to work and I meet people and I'm giving trainings for the VNGs and all. This is one challenge we are facing, that in India especially, that patients, when they initially come for diagnosis, and spending the amount of money which they have to, and if we suggest them that you need to go through a battery which is going to cost you at least 15K or 20K,
Mm.
the patient becomes a little resistant. So initially, we just try to start off with one of the findings, and if we get to a point where we are very sure that yes, it requires further investigation, we do try to convince the patient that they should go for a test battery. Usually in India, when a neurologist asks a patient to go for a CT scan or an MRI, they do not even ask a question. It's just basic for them, like, okay, we'll go. But when an audiologist suggests you to go through a test battery, which is charging this much, this is one challenge we are facing right now, which is there. We slowly move them through the battery, not the whole battery in a day, because they require evidence and like advice from a doctor, or like a review from a doctor who suggests them, okay, you can go for the further tests and all, which you can go. So definitely we try to contact the patient and we told them that this is what we need to go through. And the patient has said, as Vishnu told, that whenever they come over here to Delhi again, they're going to go through the further examination of the whole test battery, which we were saying in terms of be it posturography, be it V-hit, and other tests which are required along with it, sir.
Okay, that's now I appreciate there's those challenges that you'll end up facing, particularly when people are paying from their own pocket. An idea maybe is that you offer that BNG with a V-hit or something like that, so you have objective evidence of as a package, and that
Yes.
may be something which suits, satisfies your academic requirements and the scientific requirements to a certain extent, whilst
Yes.
also being able to at least get the patient appropriate, a reasonable package. So that might be an idea, just to think about. But
Yes.
yeah, no, I understand. And in terms of the actual further investigations, of course, I think that'll be worthwhile going through.
Definitely, sir.
Okay, for him. And audiometry and things was done somewhere else, was it?
No, here it's only this was all
Well,
normal.
you did it for
Impedance
yourself,
was
okay.
A type, bilateral A type, hearing loss by within normal limit, bilateral within normal limit,
Yeah, good.
and there were no oral fullness, no fluctuating, nothing. There no experience at all. Autological.
And of course, it's the reason I asked whether it's how many days after an attack, because interictal period, things may settle down. So again, another, I guess, way I try to look at it is whether things are improving much later on, so down the line, as opposed to their sort of stable symptoms, which makes me more worried about a more sinister central pathology, especially with episodic syndromes or vestibular syndromes. There will be that initial phase where there'll be lots of central eye movement signs, and then gradually it tends to improve. And then you get a further attack, and then there'll be those initial first few days where things are bad again. So it'll be interesting to see what the eye movements are like at a later stage.
Yes.
Sir, I followed with him, and now he's doing better actually.
Okay. Has he had any treatment at all in terms of
Yes, sir. He's
what do
going
they
through
treat him?
treatment. Uh, uh, I asked him to send me and everything, but
No,
I'm
fair enough.
busy. Okay, I'll be get home. I'll send you. So it was just like that.
Well, at least you sent him the right way. You can only get the satisfaction of that.
Yes, sir.
Okay, good. Anything else, Dr. Nair, you want to sort of
So,
mention? I think from
some questions, I mean, this is more of a question or a query as to patients who come with cluster headaches. Uh, Often they would be treated for the headaches alone. That's one of the reasons why they may not land up with you, because the vertigo becomes an ancillary symptom of the main symptom, which is the headache. Because by definition, cluster headaches are almost suicidal headaches. So one of the reasons why you as an audiovascular person's clinician may see less of these cases is that many of these cases have been disposed of by the neurologist. You know,
Yes.
Yes, sir.
it's
uh,
either a sensitized neurologist or, and that's my take. What do you think, Arun?
well, it depends actually, because we get a fair few referrals from the neurologist once they hear the word vestibular symptoms. So they wanted to make sure there's nothing else going on. But equally, they're quite happy to initiate first line treatment, exclude other things. So it makes my life a lot easier. We tend to see a lot, well, A, they're very uncommon anyway, because it's like 1 in 10,000 or whatever it is. B, yes, they will end up under the neurologist door in the first instance, but we will still end up seeing them following referral, but we're more likely to see things like vestibular migraine because they come directly to us
So,
instead.
here's my comment. I mean, this is now to Vishnu and Banish. See, the aim of our treatment and our investigation protocols in India should be to gradually reach a maturity which you already have in the NHS and in the UK, of closer collaboration between specialties. Failing this, it will be a, it comes to me, I treat it, it comes to you, you treat it, which would never be in the patient's best interest. So the request to you is try to standardize your teams, because then you know that, if you had the instead of the patient telling you what happened, you could have the clinician tell you what happened. So I know it's tricky, and I know that, in the way we practice, spread out over many places, but wherever you are, if you can start creating a team
Yes.
and preferentially keeping a cross referral, it helps you get inward referral, and it ensures that there is a completeness about the investigation. So
Yes.
just a suggestion for what it is worth, because otherwise, we'll always be at a disadvantage when Arun says, "What about this?" and you have to confess, "Look, I couldn't see that aspect." Am I on the right track, Arun? What do you think?
I highly sort of agree with that because it helps you complete the story, and unless you complete the story, it kind of always leaves that question mark hanging, isn't it? And more than likely you're likely to be right, but there's always that 1% that all of us will be wrong, even with the best of technology and the best of experience. So completing that loop will be useful,
And
both from academic and learning perspective, as well as from your own records perspective.
yeah, and going forward, see, you got one case. I'm sure in the course of your practice, you'll get many. So
Yeah.
my request to you is make sure that A, this patient, you get the other details, put it together and a follow-up details, and start maintaining isolated records of these kind of cases. So I'm sure over a period of 4 or 5 years, you may get a group of such cases. And
Yes.
see, what happens is in India, because you get one case, we tend to rush off and publish it.
Yes.
Collect patients in groups. It carries much more weight and value. One, two,
Yes.
ensure follow up. It gathers even more weight in this thing, and be quite free in sharing authorships. Nobody owns a patient. We can own only our analysis of a patient. So that's a little unasked for advice, but I think it's valuable in the Indian setting at least. Arun, you want to add in on
And
this?
I would say that I agree in the private sector or any sector where there's private healthcare, patients tend to disappear, particularly if there's a cost associated with it. And I can be a bit more liberal in wanting to see a patient again, and even free of charge for that matter, for my own academic requirements and interest. And they tend to be a lot more amenable when you say, well, actually, it's just a checkup. Don't worry, it's part of your initial appointment. Come
Right.
back in, we'll pop the goggles
Sir,
on and
I
have a look.
approached this up.
Yeah,
Sir,
you've tried it.
sir, I said I said the
Yeah.
same thing. That's why he agreed to come to Delhi again.
Good, 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 good. Well, there you go. See, so I think yes, fair enough. It's slightly vested interest, but
Yes, sir.
it works.
Yes, sir.
Cus Customarily, we open the discussion to the audience if anybody would like to pitch in before Arun would give summing up comments. So anybody in the audience is free to unmute and comment
Or put it in the chat for that matter.
or put it in the chat if it is not already. Like anybody in the audience who has seen similar cases, you're welcome to comment. Otherwise, Arun, would you like to give a summing up comments?
Yeah, well, thank you for presenting that very interesting case. And I think without complicating it too much in terms of digging into the eye movements and everything, particularly when there's a bit of a lag, I think what we can safely say is a gentleman, a young person with recurrent headaches, more in keeping with cluster headaches, and vestibular symptoms in conjunction with it. With certainly central vestibular signs, we need a bit more evidence to look at the peripheral side of things. And in terms of, it hasn't been reported that much. So you have got something on your hands if you wanted to. Then subsequently, as Dr. Naya said, get a few more cases, keep it in your pocket. And even if you get 2 or 3 cases, you can publish those. Because last time I think the papers you quoted one was 84, wasn't it? So it was a long time ago. So it'll be useful to
Yes, sir.
bring that back into public discourse again. But overall, yes, follow up and making sure that if we are considering these conditions, that we always look at it as a diagnosis of exclusion, that they've seen, had appropriate imaging, had appropriate tests.
Definitely, sir.
Lovely.
So thank you.
Yes,
I
sir.
think
Thank
thank
you,
you to
sir.
all the audience. Thank you to both Manish and Vishnu. And of
Thank
course,
you, Vishnu and
Herr
Banish.
Professor
Thank you, sir.
Arun. Look forward to the meetings in the future
Yes,
also. And
definitely, sir. This is the thank you, especially to Cyclops and Mr. Niranjan for providing us this opportunity to present. And this was our first time. Definitely, we're going to improve and come back with much more interesting cases in the future,
Right.
with much
Please
more
do.
proper evidences.
so
And
do attend every monthly meeting. I think
yes,
now
definitely, sir.
going forward, you'll
Now we have
get
entered the system. We're going to make sure that we stick to it and we are there. We are observable all the time, and we are also absorbing as much as from your guidance and your discussions and all. It's going to be very helpful for us, both of us. And I am also going to make sure as I'm traveling and meeting doctors, CNTs, and neurologists that I discuss about if I can extract now, as you told me, if you are able to gather 4 or 5 cases. So wherever the VNGs are there, if we can contact them and just tell them that we are going, like, we want these cluster headache cases which are there. And so that is going to be primarily my job now to make sure that more and more of the cases do come. and I'm going to make sure, like, in a short span of time, as much as possible, we can gather such cases. We have made different sections of cases, as me and Vishnu both have seen a lot of cases together. Also, almost, I would say, up to 500 cases we have seen in Sarvodaya Hospital together. We have seen, we were concurrent and, agreeing to the clinical examinations and all. We were seeing whatever I used to see. I used to ask him also that, what are you feeling? What is your say in this? So we have categorized them. And because this was the first time, we wanted to make sure that this is a little bit different, unique case. But we have other cases, sections also in peripheral and central, which we have at least 15 cases which are there. So the next time when
Well,
we come,
I mean, if Arun would be willing, I think you all should touch base with him because he
definitely,
would
sir.
definitely give you. So I think I would leave us all at this point. I think it's promising. We hope that this will progress. Arun, you
Definitely.
have any last words you could?
No, no, well done to the both of you, and yeah, absolutely look forward to seeing a lot more of you as in future.
Yes,
Yes,
definitely, sir.
definitely, sir. Thank you
Thank
so
you.
Okay,
much, sir, for this
Thank you.
opportunity.
Thank you.
Okay.
Thank you
take
very
care now.
much. Thank you.
Okay,
Good
Bye-bye.
sir.
night. Good night. Yeah. Bye,
Uh,
Arun.
Good night. Take
Yeah.
care.
Okay, sir.